It's an epidemic that kills well over 100 people across the country every day.
Families are being split apart.
Threatening to consume our friends, our neighbors, sometimes even our own loved ones.
I didn't realize that this was and is a disease.
It just tears your family apart.
Tonight, those who know show us the profound and devastating impact of the opioid crisis as experts help us to understand how Southern New England is fighting back.
We are moving forward.
You're watching an ABC 6 News special presentation, The Opioid Crisis, Where We Stand Now.
We are gathered tonight at Brown University in Providence in the hope of shedding new light on the opioid crisis here in Southern New England. Good evening and thank you so much for joining us. I'm John DeLuca.
And I'm Christina Myers. In our ongoing effort to raise awareness and erase the stigma of addiction, ABC 6 News has been running a series of special reports all leading up to this evening. And our host tonight, Brown University's School of Public Health. So we do want to take a moment and recognize and thank Dean Bess Marcus for making all of this possible. Thank you for standing, giving us a wave.
Also helping us tonight, a team of experts on the epidemic. They have knowledge ranging from first response to treatment and recovery. They're going to tackle the issues and answer your questions.
But first, we want to hear from some people who know firsthand the devastating impacts that addiction can have really on anyone. ABC 6 News reporter John Krinjak starts us off tonight with an effort to help families who are dealing with this epidemic.
Karen Kaplan's daughter Heather began using opioids at 16. Her drug of choice, Percocet.
She fell in love with the high and became addicted to opiates and went into doing crack and shooting heroin and basically went through everything.
With Heather in and out of rehab, sometimes disappearing for weeks at a time, the addiction put an incredible strain on the entire family.
It's a disease that it just tears your family apart. You start with blaming yourself. I was ill inside, constantly worrying about my daughter, not knowing if she was going to be dead or alive.
For Catherine Diorsi, it was her brother David.
Out of our entire family, he really was the most loving of them all. No matter who you are, he was always willing to give you the shirt off his back.
But his addiction to pills and alcohol turned into a 20-year battle.
He was tortured every day, as was my family.
It was especially tough on their mother.
She never gave up on him. She always wanted to give him a place to be home.
David's mother was the one who found his body 10 years ago.
She said, David's dead. His pockets were filled with nips and pills and, yeah.
It was families like these, as well as addiction and overdose within her own family, that made Lori McDougall realize there was a need here, not for the addicts themselves, but for the people who love them.
They're just desperate. They're beaten down and they feel guilty. That's not what I see. What I see is a family desperately searching for solutions for their loved one.
She started a group for families of those addicted to support and educate them.
We're going to identify, or at least try to identify, some of the things that we do with our loved ones.
McDougall uses a method called CRAFT, Community Reinforcement and Family Training, which covers everything from minimizing triggers to how to talk to your loved one without pushing them away.
It's a very family-driven. What does the family want? How does the family want to attack this problem? And how can we meet you where you're at?
Diorsi wishes she had access to something like this while her brother was still alive.
As a family, we didn't do any of these things. We kind of just dealt with it.
Karen Kaplan's daughter Heather is 5 years in recovery.
To know that there's a community out there that's suffering like you are, that are willing to help you and support you, makes a world of difference.
And both Kaplan and Diorsi are now involved with the governor's task force to combat the opioid crisis. Meanwhile, McDougall says she hopes to see the peer support method continue to grow for families, much in the same way it's become the gold standard for helping addicts. And for more on where you can find help, just visit our website, abc6.com. I'm John Krinjak, ABC 6 News.
Now, you may recognize some of the folks on our panel from the story we just had with John, Lori, Karen, Catherine. Thank you so much for joining us tonight and being part of this series and for sharing your story. We also have two peer recovery specialists we'd like to introduce you that are on our panel this evening. Katie Gonzalez from the Parent Support Network, who specializes with helping expecting mothers in recovery, and Tanya Cabral, who is a community trainer for RICARE and an outreach case manager for House of Hope. Ladies, thank you all for joining us tonight. I know this isn't easy, but we do appreciate your time and effort. And trust me when I say this, it really does make a difference. Lori, I want to start with you. People at home see this story and they say, that's my fill in the blank, daughter, grandson, brother, whatever. They think, I'm hopeless, I need help, I don't know what to do. They think there's no help out there, but you're here to say there is help. What help is available for them?
Well, there are a ton of resources out there for families, but most families are not aware of it. There are Al-Anon meetings, Nar-Anon meetings, codependency meetings. There are professional counselors that can help families, but also a new kind of meeting, REST, Resources, Education, and Support Together, that's based in something called CRAFT, Community Reinforcement and Family Training. And CRAFT is an evidence-based methodology to help families learn about better communication skills, better interaction skills, to help improve the interaction within the family unit, so that you can learn to communicate in a better way and get the best out of your loved one with substance use disorder. It's a way to stay engaged.
But you have to take that step.
You do.
And there's a lot of things that you just said that help, and that's the good news. There's a lot of opportunities and avenues for folks. But at the same time, what do you recommend, through your experience, the first thing they should do? And I want to get help. I know my fill in the blank has a problem. What do you recommend? What's the first thing they should do to get help?
Well,
the short through all the stuff you just said.
I personally, what would I do? I would attend a REST meeting. I would go straight to a REST meeting, simply because we don't, yes, we work on the emotional piece of it. We really provide a lot of support on the emotional end of it. We also have, we are, how do I explain this? We are a group of families that really are compassionate, caring, supportive, non-judgmental, and we basically are saying, look, I know that people say we're enablers. I know that people say that we are...
Who's saying that?
Pretty much everybody. I mean, that's
people who don't know, who aren't in this
situation.
situation. That's who's saying it.
Yeah, that's who's saying it. People who don't know do a lot of blaming and shaming. So there's a lot of blame and shame put on the person with substance use disorder. There's also a lot of blame and shame that's put onto the family as well.
As if they've done something wrong.
Right, exactly. And we believe it. I mean, we really, really believe that we did something wrong as a family member that pushed our loved one into substance use disorder. And I would say, I guess the first step then is to find some way to overcome the stigma and reach out for help.
Karen, we saw in John's story about your daughter, which is great news, that
Yes.
things are going well.
Wonderful.
We turn back the clock, though, when things weren't going so well. Some of the signs that you look back on and go, oh, geez, I was making excuses, or I thought it was this. When did you know, and when did you know something's going to change, or this is not going to end well?
Actually, one of the first signs were the teens that she was hanging with.
Her friends?
The group of friends.
Okay. Did it change dramatically from what it was at one time?
Yes, yes, it did.
So people you were comfortable with, to people like, who is these, what are you?
Yes.
Who is that? I
exactly.
don't know him, I don't know her.
Exactly.
Behavior
and her
changed?
attitude changed, yeah, her attitude towards me. We were always very close. She was always very respectful.
And how old was she at that point when that started?
16 and a half to 17 is when she started with the use. She went to a party, and like I said on the piece before, that she took a Percocet, and that was pretty much it for her. After that, she went, within months to heroin, and that's how most of them do start, with a pill, and often they'll get it from the family's medicine cabinets. That wasn't the case in our instance, but. And then heroin is a lot less expensive, and that's the way that they become heroin addicts. She never expected to be an addict. She never expected to be shooting a needle in herself. And
yeah, the pill doesn't have a disclaimer on it that says may lead to ruining your life or anything. No.
Right. So, yes, and the first thing that I did actually was call my insurance company when we found out about it. Yes, because they all have a behavioral health number. and so they can help you with pointing you towards the areas that you can get help. So that was the first place. Rest wasn't, you know, this was a decade ago, over a decade ago,
okay,
when I first found out about her addiction. And so that's what I did first, was call the insurance company, and they were very helpful.
As you look back on it, do you feel like it was the right thing to do at that time?
Yes, it was. I also spoke to BHDDH when I ran out of options, and I called someone. I went to a rally for recovery. Someone told me, you should call Rebecca Boss at BHDDH, and she wasn't in the position she's in now, but boy, she opened her doors. She gave me a ton of resources to call and trying to get places for my daughter. She went through 13 different rehabs and detox centers.
So the message here is don't give up on your child.
No, never give up. Never give up.
People think, oh, it's been 5 times, I guess they're not going to get it.
You feel it's hopeless. It's so painful, and it tears the family apart. When they're in active addiction, they steal from you, they lie to you. And I knew this wasn't the daughter I raised. She was so loving and caring, and so you try to look past that, and you try to help her in any way you can. And
you must feel helpless at some moment.
Oh, constantly. Yeah, my whole life was worry, you know, one constant worry. You go to work, but still 24/7, your mind is on your daughter, and you know, what can I do? Is she okay? Is she using? Is she going to overdose today? Is she going to overdose tomorrow? Luckily, we never went through an overdose, but of course, all of that's going through your mind. And back over a decade ago, there was a lot more stigma involved. You didn't want to tell people, so only close family knew. And you know, thank God I have a very supportive family, and they helped me through a lot of it.
Catherine, in John's story, you mentioned, I wish they had this. We had none of this. And your brother was going through what he was going through. As you see it now, looking at it, how much more would that have helped in your situation? And do you feel like your family would have taken those steps to say, look, as I'm sure your brother would be like, no, I don't want to get involved with that, or there's a resistance or pushback. You know, as you look back on it now, do you feel like it would have made a difference?
I mean, I definitely think it would have helped. I think really one of the biggest things that I don't see being showcased enough is the non-opioid treatment options that do exist. I believe that the solutions are already here, but...
What are those, Catherine?
There's naturopathic medicine, there's acupuncture, there's mindfulness training. I mean, a lot of this, my brother was in the Navy, and so many things happened to him in the service, and he was normal prior to that, you know? He was a football player, he had girlfriends, he had a ton of friends, he was in great shape. Went into the service, a lot of things happened, ended up injuring his back. That's how he got OxyContin for the first time, and he was honorably discharged. And when he came home, all he got was drugs. You know, OxyContin, 90 sent to the house. You go to this doctor, that doctor.
For a doctor, he got him prescribed.
Oh yeah, yeah. Every doctor he went to.
What year are we talking about, roughly?
It was 86.
Wow.
Yep, so, and then it just becomes, at the same time, the services aren't available, and they were only talking about medicine, and then, you know, the stigma is there, and then also, too, it's the mental component. If you, every one of us, whether you're addicted or not, we all have stuff that we need to all deal with so that we all can heal. And when you're addicted, it's even more so. There's stuff that you are blocking the pain from, whether it be physically, mentally, spiritually, emotionally. And so that wasn't available to him, but we have those resources today. They all exist. They've been around for thousands of years, but are we really either using them? Are we making sure that they're available and everyone can get coverage? They're our insurance company. So I think in addition to all of these services to help those that are recovered in the families, we also need to amp up the non-opioid treatment options and do everything to make sure that everyone has access and education and support.
Well said. Katie, you deal with expecting moms in recovery. Mm-hmm. Tell us a little bit about what you do and what happens to the babies. Are they born addicted to whatever the substance is, and how do you treat those moms?
I work for a program called Healing Mothers and Babies, which is pregnant moms on either methadone or Suboxone. So what I do with these girls is I bring them their prenatal appointments, any other appointments they have, just to keep their babies healthy. because our end result is that they don't have DCYF involvement. So we try to get them, you know, in family visiting, the nursing.
Tanya, you're the community trainer for RICARE and an outreach case manager for House of Hope. I understand you teach people how to use Narcan.
Yes, yes, I do.
When people hear use Narcan, they go, I don't want to do that. How hard is it? Hard, and how much do you need to help somebody who's overdosed?
Well, it depends. There's a stigma like everything else that goes along with naloxone and Narcan, because the common attitude seems to be like, well, why bother? You know, that person's doing that to themselves, so why are we going to waste all this money?
Who are the people saying why bother?
The people who, like we were saying earlier, the people who maybe aren't affected by it, the people who don't understand, the people who don't care to understand. Okay. Those are the people saying that. Because, I mean, I've had people ask me how many times I believe somebody should be allowed to be administered naloxone. So I always answer that with, well, I personally don't put a limitation on somebody's life. Like, you know, I mean, even our Attorney General equated having naloxone and being able to use it as the same thing as being able to administer CPR or use an AED machine. Sure. It's a life-saving technique for folks. Because we're coming from the place where it's harm reduction, but we're trying to keep that person alive, so hopefully eventually they will get the help like we had.
And when people hear, because I've talked to firefighters and police officers for that matter, who have given Narcan and then the person is revived and they're mad. Mm-hmm. What do you tell the person who just gave that Narcan? Because you feel like, what do you mean you're mad? I just saved your life. I mean, how do you deal with that emotionally?
When I do my trainings, I usually tell the person to take a step back, because if that person has an opioid tolerance, they may go into withdrawals. So they're not going to be thanking you for saving their life. They're going to be upset. Not only did you ruin their high, but you also made them sick. So I always tell people when they're going to administer, we're number one, so we have to make sure we're safe, so you just take a step back. And if it were me doing it, I would get out of there. If the person was combative, I would get out of there. Now before, and I always tell this is the number one thing, before anybody administers naloxone, call 911. So 911's on the way. Okay. So if I have to get out of there to keep myself safe, I know 911 is going to come and help that person.
And if you've given it properly, how long should it take if the person responds? Within?
Well, approximately, we say like a minute to 2 minutes, but that also depends. I mean, if it's somebody who doesn't have a lot of opioid in their system, it could work. And if it's somebody who has a lot, it could take more than one dose. But there's never like too much. You can't give somebody too much of it. Like
okay,
you can just
so there's no, I gave too much in the law.
No.
Okay. Oh, that's good to know. Ladies, thank you so much for joining us tonight. And I want to thank you for being a part of our discussion. It's flown by. On a personal note, I do want to thank each and every one of you for coming in, because when you talk as real people transparently about a very difficult subject, something that's impacted all of you, people stand up and notice that, and it makes a difference. And you have made a difference tonight by being here. Thank you for your courage and being a part of this. We really do appreciate it.
Thank you for having us.
Yes.
I would like to take a moment now and talk about the resources that are out there that we've just discussed for anyone who needs help or anyone who wants to help a loved one. Christina has more on that.
Thanks, John. Well, all evening you have been seeing some of those resources at the bottom of your screen. There are a growing number of recovery centers available out there. If you are looking for one that's near you, or maybe you'd like more information on outreach efforts or the organizations represented here tonight, all you have to do is head to our website, abc6.com, and click on the Opioid Crisis link. We have a whole list of resources right there for you. And again, you can also always call any of the numbers that are listed at the bottom of your screen. Among the ways Rhode Island is trying to tackle the opioid problem is through the hotly debated Kristin's Law. ABC 6 News reporter Chloe Leschner takes a look at why this law is dividing the very people fighting the opioid crisis.
It's been 5 long, tough years for Sue Kutu. 5 years since her daughter Kristin took a fatal dose of fentanyl.
Kristin used to say that she had a hole inside of her that she could never fill. And when she used heroin, she said it filled the hole.
Kristin struggled with addiction for 3 years. She wanted to get better and put herself in rehab. Less than 24 hours after getting home, she died.
She had a dealer that she had used before. He was readily available. It might be, very innocent thinking, or naive thinking, but maybe if he wasn't available, maybe she'd still be alive.
So she helped push Kristin's Law through the General Assembly, a law that puts life in prison on the table for people who deal a deadly dose. 7 months later, one person in Newport has been charged under the law. Some say that's one too many.
Does he need to get up to life imprisonment? Is that going to bring back that dead person? No.
Dr. Jody Rich, a prominent member of the treatment community, says Kristin's law is a step in the wrong direction.
Kristin's law will discourage people from calling 911 if someone overdoses for fear of arrest and prosecution. It may end up more people get hurt by Kristin's law than helped.
Kutu says that's why there's a Good Samaritan law, protecting those who call 911 from being charged.
It's trying to find people that are major drug dealers and dealing in large quantities.
And with that as the purpose, the new Attorney General, Peter Nerona, says they'll be careful when deciding to charge people under Kristin's law.
It's somebody who is in the business of selling narcotics and doing it as a significant business. They know exactly what it is that they're selling. Don't care about the impact of what they're selling. Don't have a relationship with the person who overdoses.
But those cases will be few and far between. He says while law enforcement plays a part in the opioid epidemic, the priority is to get addicts the help they need. And at the end of the day, that's Kutu's goal, to keep other families from experiencing the pain she has, and to keep Kristin's legacy alive.
Kristin was someone who loved to help other people, especially underdogs, and so I think she would be happy about this.
Attorney General Nerona says he's encouraged police departments across the state to use Kristin's law sparingly, and that anyone who's there when a person overdoses should still call 911 without fear of spending life in prison. In the newsroom, Chloe Leshner, ABC 6 News.
All right, before we get into our discussion about Kristin's law, I'd like to introduce our new panel members. Bear with me if you would. To my left, we have Brandon Marshall from Brown University School of Public Health. Dr. James McDonald, who is the Medical Director for the Overdose Prevention Program at the Rhode Island Department of Health. Linda Mahoney, Administrator for Program Services at the Rhode Island Department of Behavioral Health Care, Developmental Disabilities and Hospitals. Linda Hurley, President and CEO of Kodak Behavioral Health Care. And Captain Zach Kenyon from the Providence Fire Department, who heads up the Providence Safe Stations program. Ladies and gentlemen, thank you for joining us tonight and being a part of our panel discussion this evening. All right, show of hands. Who thinks Kristin's law is a good idea? No one. How come? Dr. McDonald, let me start with you.
You know, it's an emotional space we're in when we talk about this, because obviously you're sympathetic with the parents. They've lost somebody, and we're sympathetic with everyone, but really I think Dr. Rich had a point. We don't want to discourage folks from calling 911 and getting the help they need. And you know, it's not so clean, it's not so cut and dry. So often the dealer is a user, and so often the person who's selling needs medication-assisted treatment as well, or some kind of help. It's just an emotional space. So I'm not sure that strategy, although perhaps well-intended, was the best use of our judicial resources. I love what Attorney General Peter Nerona said. His intention is to use it sparingly and to look for situations where it makes the most sense. And I trust Peter Nerona to do the right thing.
But why, if we look at this, step back and say, why are we trying to do anything that would protect a drug dealer who's knowingly putting fentanyl into a product he or she is selling? Why wouldn't we want to do everything we could to deter that person from taking the fentanyl out and saying, look, if I sell this to somebody and they overdose and die, this is on me. I don't want this. Almost like gun use in a crime. You use a gun to commit a crime, the penalties are much more severe. Why wouldn't we want to have the same kind of things in place for somebody to say, you know what, I'm not going to put the fentanyl in? Because we would all agree, and we'll talk about this in a few minutes, about the human eraser that fentanyl is and how a problem it is. What do you say to that, Brandon?
Yeah, it's a challenging issue, and I agree with Dr. McDonald that I can't imagine the pain that comes from losing a child due to fentanyl and the desire to hold people accountable for that. I think the concerns from the public health community are fairly clear, that we have concerns that this law may encourage people not to call 911 in the event of an overdose.
Can't the Good Samaritan law protect you?
Exactly, and so I was thrilled to see those amendments go through with that bill that ensure that those protections are in place. So I think that's a great step forward. I think the other concern as well is that unfortunately the demand for these substances is very large in our state, as in many other places, and so you risk, by incarcerating and removing one dealer, a rapid replacement with someone else, and that product continues to go out on the street. So I think we need to focus on trying to access encouraging access into treatment and reducing demand ultimately for these substances will probably lead us to a better place in terms of reducing mortality overall in our state.
Linda Mahoney, your thoughts on Kristin's law?
Well, I'm about treatment and recovery, and I believe that every person who might be in the throes of active addiction has a mind that's altered. And if they have the opportunity to step back and to be in a safe environment, that their life can change. Kristin's law has a wide scope. So if you talk to some parents that have injured, as Dr. McDonald said, we want to have that life for a life, right? When we're looking from my perspective, I've seen so much in recovery where people are not knowing what drugs that they have or what they're using. They don't know if there's fentanyl in it because it comes from places they don't even know where it comes from.
So the argument to protect them from people who are knowingly lacing the drugs with fentanyl.
So for me, the purpose is take an individual person by person. And I think that part of the Kristin law is to be able to meet the person. If you know where they are, what they've used, whether or not they're dealing or whether or not they've just have a small amount on their system, meet them individually where they are and give the judicial system some information about treatment and recovery and give people a chance to have a life.
Do you have confidence in the judicial system to do that?
I have confidence in, I have to have confidence in the judicial system because my belief system is that if you have the opportunity to stand and do your best, that the law is there for a reason, and the judicial system will do its best to kind of get that right reason done.
All right. Christina Myers has a viewer question to weigh in on this topic. Christina.
Thanks, John. Our first question comes from a viewer named Beth who wants to know if any other states have something similar to Kristin's law, and specifically, how does Massachusetts handle this issue?
Who would like to take that up? Are any other states that have a Kristin's law that you're aware of, and what does Massachusetts do to handle this? Anyone?
I can take that if you'd like it.
Okay.
These drug-induced homicide laws have been implemented in other states. Florida has passed even more punitive legislation that doesn't have some of these added protections that we have in Rhode Island, protecting the Good Samaritan law, not having mandatory minimum sentencing in place. So there are other states that are going to this as a mechanism. In terms of Massachusetts, in particular, a similar bill called Stevens Law has been filed, but has not yet been discussed in the legislature. So I imagine this year we'll see whether that comes.
And I don't know if you know this or not, and if you don't, I'm not trying to put you on the spot. The other states, have they had any success or failure with it? Any numbers to say that opioid deaths are going down or illicit fentanyl deaths are going down? Anything with that?
I think it's too early to tell. The first person that I know of under the Florida law was charged in just last October. So, many of us have concerns that this is the right approach to take. Ultimately, we will have to wait and see the extent and the number of people and the types of people that are charged under these laws.
It's a nice segue, Brendan, to bring in Linda Hurley. What do you expect to see? We've said 7 or 8 months that Kristin's law has been on the books. What do you expect to see a year out from now, 2 years with Kristin's law? What would the impact have been?
Again, this is conjecture, but my expectation personally is that we're not going to see a huge shift anywhere from the law. I have to, excuse me, I have to echo what my colleagues have said in terms of a deterrent. Often those that are selling don't even know that fentanyl is in their product. And as Linda Mahoney referenced, they're being driven by their own disease. So to have consequence change a disease-driven decision is an unrealistic expectation.
So, Captain Kenyon, from your perspective as a first responder, how do you perceive Kristin's law? Would you like to see some law in the books to penalize fentanyl dealers who are knowingly pushing this?
Well, I think Brandon actually hit it on the spot on his first comment, was that, if you put one drug dealer away, it's not going to stop the drugs from hitting the street. You're still going to have all these drugs out there, so that one dealer getting put behind bars doesn't change the scope of what's happening. I'd rather have somebody call 911 so we can revive that person with Narcan and give them a second chance at being able to come into the safe stations, get connected with recovery coaches, and a second chance at life.
Do you think there's any chance, and maybe Dr. McDonald could answer this, at the State House, since the medical community feels so strongly about this, that this is not a way we're going to prosecute our way out of this, that Kristin's law will be changed or amended in some way that takes into account what you folks are talking about?
Yeah, I haven't seen that introduced yet this year.
I haven't either, but maybe because it's too soon, but maybe
yeah, it might be too soon. And I think, one thing to keep in the back of our mind is we're making progress with the epidemic. I've lived and breathed this epidemic every day for the last 7 years. And as much as I would love to find one simple solution to solve the epidemic, that is not going to happen. I understand the motivation for these types of laws. I just don't think that's the best use of our time. There's a lot of drivers. Money is one of them.
Yes.
One of the things I learned from the high-intensity drug task force is a kilogram of fentanyl that often starts in China that might take a few $1,000s to produce, by the time it's sold in the United States is worth $10 million. The financial drivers are huge. The people who are using the products have a compelling addiction and they need our treatment, our help. And it's a very complex social, biopsychosocial epidemic, and simple solutions aren't going to solve it.
It's not that black and white.
It's not that black and white. And I think sometimes we love to reduce things to yes and no, here and now. This just isn't that simple an epidemic. That's why the whole country struggles with it. That's why there's so many efforts from so many different good people to try to come to a great solution to it. And the progress we're making isn't because of Kristin's law.
I'll hit the pause button right there. We're going to change the conversation and talk about pain. One element or one strategy to helping reduce this epidemic is reducing the number of prescriptions that doctors can prescribe for opioids. You're seeing it in Rhode Island, you're seeing it in Massachusetts. It's definitely reducing the number of prescriptions, that's for sure. But folks who are living in chronic pain say, you're punishing our pain. Let's take a look.
Claudia Morandi grew up with pain. Just like her father, she has Crohn's disease.
I spent 10 years of my life at Miriam Hospital. After my second child was born, I came out of remission, couldn't get back in remission. I had a colostomy bag.
Thanks to pain medication, chemo, and physical therapy, she has her life back.
The suffering was too much with my illness, and for me, pain management changed my life.
Her life and the lives of countless others living with chronic pain changed a few years ago when the CDC created opioid prescribing guidelines.
I understand that there was a good intent, but it wasn't well thought out. It was a disaster.
In an effort to cut down on years of overprescribing highly addictive opioids, which contributed to the epidemic, doctors everywhere were suddenly being monitored and warned by their respective state health departments.
A lot of the messaging from the federal and state level to providers is that prescribing of narcotics in any circumstance is going to be questioned and problematic.
Now, even people in chronic pain who were prescribed opioids for years are being abruptly cut off or having their meds drastically reduced.
I can't find any doctors in Rhode Island to prescribe to patients.
I think that chronic pain in particular is an area that a lot of physicians are afraid to tread.
Dr. Kevin Bale is a psychiatrist at Butler Hospital who specializes in addiction and severe mental illness. He's also a member of the governor's opioid task force.
There's really not a strong evidence base for use of opioids for chronic non-malignant pain. And patients' quality of life is not often very good, even if they are maintained on short-acting opiates for long periods of time.
One fact that's hard to ignore: opioid prescriptions are way down, but overdose deaths are still high. On this point, the patient advocate and the doctor agree. Fentanyl is to blame.
Fentanyl is essentially an environmental toxin, especially among illicit drugs.
We don't have a prescription pain medication problem. We have an illicit fentanyl, heroin, overdosing epidemic.
All right, I want to start our next discussion now where we ended that package on pain, talking about fentanyl. It seems like we were just talking about it in Kristin's law, but we're talking about it again for obvious reasons. Dr. McDonald, I'd like to start with you. Fentanyl, you're seeing it in all these drugs, these illicit drugs that people are overdosing on. Is the problem fentanyl, or is it overprescribing?
So it's both. I mean, again, it just isn't that simple. The deaths we see in 2012 were prescription drug-related deaths. A very common death in 2012, someone got Vicodin, and they died on that. In 2018, 18 and 19, 2 out of 3 deaths is from illicit fentanyl. How people get introduced to the illicit drug market is through the prescription drug market. So how people get this introduction is by a legitimate means. You go see the physician, you get a prescription for an opioid that you may or may not have needed. And quite frankly, for a percentage of the population, they get this genetic trigger, all of a sudden life changes. You saw that from one of the guests who was on earlier. And I think it's this larger issue is, you know, in the world of medicine, we need to practice compassion first, look at the whole patient. We go to school for an awful long time, but judgment is what we do. I worry when I hear about people just stop doing anything, because physicians are bright people who have a great deal of thought and need to individually assess each patient and decide what's best.
But they feel like they're being monitored and they worry that they're going to lose their license or they're going to be raided by the DEA. How does Rhode Island keep an eye on doctors and track them? And what does the letter say? Let's say you notice Dr. Smith has written 25% more opioid prescriptions than Dr. Jones. What does the letter say from the health department to make Dr. Smith say, well, I don't want to do that anymore? Oh, but I have a bad back and I've got a pain, and you know that person's in pain and they probably could use the opioids and they probably are a good candidate for it, but they decide not to do it.
Yeah, so we don't have any rule, regulation, or law that forbids any prescriber from prescribing.
No, I understand that, but in
an opioid.
reality, though, what does the letter say that gets a doctor to be afraid to write a script?
So we don't send letters. We do have a computer program we use through the prescription drug monitoring program. One of the things that prescribers asked us to do was have the PDMB send passive alerts. So there's no one at the health department looking at Dr. Smith's prescribing. We don't do a Big Brother surveillance type thing. What we do, though, is we send clinical alerts. One is, if you have a patient on more than 90 morphine milligram equivalents per day, in other words, a high dose of opioid where a person's at a higher risk of an accidental overdose, then the alert says to you, have you considered referring this patient to a pain management specialist? Have you just considered that? Another alert we say is if you have a patient who's on an opioid and a benzodiazepine, a sedative type medicine, a dangerous combination, are you aware there's a black box warning? So these computer generated alerts are generally given to the prescribers so they can at least be aware, because they're not always the only prescriber for their patient.
Have any doctors, to your knowledge, in Rhode Island been penalized or warned?
So the physicians who get in trouble with the state medical board start with a complaint. So we got a complaint about the physician first, often from the family member, sometimes because the family member has passed away, other times because the family member sees the person being dependent or addicted. We do an evaluation of the standard of care and if the rules or regulations have been violated. You know, one case that comes to mind was Dr. Mashali, who's now in federal prison. There were 6 people who died under his pen in Rhode Island. His license was suspended several years ago, and thankfully it was. And the point I'm making is the dangerous physician isn't allowed to practice in Rhode Island. The rest of the physicians, though, we do an awful lot of continuing medical education. I've personally given over 80 different talks. What our rules and regulations say, how to follow them. What we're empowering the prescribers to do, practice good, sound medicine, use the prescription opioids when it's appropriate. But like one of the things Dr. Bale said is, the evidence base that chronic opioids help the non-cancer patient is really thin. And like one of your speakers said earlier, there's a lot of non-opioid options for people that's much more effective for pain. And those really need to be explored.
I'd like to talk about that if we have the opportunity, but I know Christina has a question from a viewer. Christina?
Thanks, John. Carlo Berger is a therapeutic massage professor at CCRI and asks, how can we change the culture around pain management in Rhode Island so people are taking less prescription opioids and instead are managing their pain in safer and healthier ways?
Dr. McDonald, can you address that?
Yeah, I think one of the things we have to look at is prescription opioids are the very worst tool we have in the toolbox for chronic pain. There's other tools in the clinical toolbox that we need to avail ourselves to that's much more common in Europe and other parts of the world. Acupuncture, chiropractor, massage, those sounds like alternatives in Rhode Island and alternatives in the United States. But throughout the history of medicine, the history of our country, and the history of the world, those are actually mainstay ways of treating chronic pain, and they're much safer. Just to throw a little statistic out, in Europe, for every 1 death, where there's a death from an opioid, there's 20 deaths in the United States. We need to learn from some of our neighbors in other parts of the world, because what they've learned is outpatient prescribing of opioids doesn't equate to a healthy community. Now, we allow outpatient prescribing of opioids in the United States and Rhode Island. We just ask that when it's done responsibly, compassionately, and effectively.
Captain Kenny, I want to talk to you about Providence Safe Stations. Briefly, if you could, what is it and how did it come about?
So the Safe Station program is set up so anybody at any time can come to one of our 12 fire stations in Providence and ask for help with recovery. We call recovery coaches who then come to the station and meet them and then help them in the next step and the next process for their recovery. It came about really because as a first responder, we've been giving Narcan since I got on the job in 2001. It's not a new thing for us. And it really becomes a mental burden on the first responder to respond to the same people over and over again and feel that you can't help them. So I decided that we had to change the way we help people. Rather than just going out when they call us, we had to make ourselves available when they wanted to come to us and really change their lives.
Are you aware of any other departments in the state looking to do the same thing that's happening in Providence?
So a few other departments have contacted me. Newport, I think, is really putting forth an effort. I've met with some other people through the statewide code meeting about doing it also. Originally, this was started in New Hampshire. New Hampshire is very, very busy, Manchester and Nashua, so we copied their programs with their permission. And we have a very high retention rate because we are targeting people when they're looking for the help, which I think is one of the keys to the program.
Linda Hurley, what would you tell a person living in chronic pain who says, I need my opioids, I need that prescription, I can't get it. I used to get 4 a day, now I get 2. And as a result, if I don't get them, I'm going to turn to a street drug or think about suicide.
And that's a conversation we have. It really depends on the individual. One of the things that Kodak has developed and other treatment providers as well, and speaks to the question that came up earlier, is to say that there is available alternative pain. We have a program called Pain Solutions, and with Dr. Frank Sparadio, and there are others in the state. But the goal of the program is to talk about the pain. When somebody comes to me, and I've gotten the calls, and it's been, I don't know what to do, my doctor's retiring, I can't find a physician anywhere that will continue to treat my degenerative spine. That's a real one that I actually held for a long time. And so to make programs available so that they become mainstream, utilizing what Dr. McDonald was talking about, acupuncture, massage, chiropractic, mindfulness techniques, the more they're used, the more we talk about them, the more the culture is going to shift. And of course, there's always going to be that added edge of the necessity of having those services also be respected in a financial way so that there's reimbursement for them.
Well, that's a perspective. I'm glad I brought that up to you because you're dealing with people who have come to you in that exact situation. I'm in chronic pain. I need this help.
That is exactly the words I've heard.
Thank you, Linda. We're going to take a quick break. We want to thank our supporters. And when we return, we'll talk more about what's being done to fight the epidemic and what is coming up in the future. You're watching an ABC 6 News special presentation, The Opioid Crisis, Where We Stand Now.
Addiction is such a hard disease and people just don't understand how it can get into families. I lost 2 sons to overdose. For the person that is using and they think that they're all alone, they're really not. There is so much more to life than this addiction. Don't be afraid to reach out because the people that love you will be there for you. There's so much support.
For years I battled addiction and lost. My friends and family had given up. Then they heard of Providence Safe Stations. 1 year ago, they brought me to a Providence fire station. Kindness, compassion from the firefighters, and recovery coaches that came right to the station, it all changed my life forever. If you are struggling with addiction, go to a Providence fire station, anytime.
We are here when you are ready.
I'm Dr. Sarah Becker. At the New England ATTC, we support professionals out in the field to ensure that patients with substance use disorders receive the best quality care possible. The goal of the ATTC network is to support the workforce that treats individuals affected by substance use disorders. Not all treatments for addiction are created equal. Our ATTC addresses this problem by helping to train providers in those treatments that we know work best.
My dad's heart attack was the scariest moment of my life. The fear was overwhelming. When my sister told me Dad was in the ER, by the time I got there, they had already accessed his medical record through Current Care. Dad sees doctors all over the state, but they were able to track his medications, lab tests, and radiology reports all in one place. That's Current Care. He raised me, took care of me. At his age, it's my turn to take care of him. Dad gave us a scare, but thanks to Current Care, he's still with us.
Current Care, in partnership with Rhode Island's medical community, helps your doctors provide you with the right care at the right time. Sign up for free today. Go to currentcareri.org and click Enroll Now.
Welcome back to this ABC6 News special presentation, The Opioid Crisis, Where We Stand Now. And now we want to take a moment to highlight one way Rhode Island is leading the pack when it comes to addiction treatment. At the ACI, a different approach to recovery is helping inmates change the direction of their lives. ABC6 News reporter Alana Cerrone takes a look at why it's working.
Inmates are at a high risk of overdosing when they get out of prison because the tolerance they build up while using is cut back while they're incarcerated and out of the reach of drugs.
15% of inmates at the ACI suffer from addiction. And they suffer an even greater risk outside prison walls.
The first 2 weeks after release, there's 129 times greater risk of death from an overdose.
But here they have a fighting chance at beating their disease and surviving when they're released. Just ask Ramon Barriera.
I won't be here to tell the story.
He says he could have overdosed and died when he got out of the ACI, just like 2 of his friends did. But he was part of the medication-assisted treatment program, which screens inmates at intake and, if necessary, puts them into the program right away.
We've seen a 60% decline in overdose deaths of formerly incarcerated people coming out of this prison system who've received MAT.
Its results have gained national attention.
We are a model for the nation. We get contacted weekly by other states, systems wanting to learn how we did it, how it works.
It's even caught the eye of former New York City Mayor Michael Bloomberg, who visited the ACI last year.
Bloomberg Philanthropies is about to start a program to fund some studies and some programs that we think will help. We took a look, and Rhode Island was actually doing something interesting.
As part of the program at the ACI, every correctional officer and inmate has the opportunity to learn how to administer Narcan. In the newsroom, I'm Alana Cerrone, ABC6 News.
Linda Mahoney, I want to start with you. This seems like a very progressive approach for the state of Rhode Island to take. People going in saying, you know, I have a drug problem, I'm in prison. Many states just throw away the key. And then they get out of prison, get right back into, or at least trying to get back into that lifestyle again in either overdose or get into trouble as a result of trying to get drugs to feed that habit. Tell us about Rhode Island in its place right now leading the way with this.
Well, you know, it really took political will and many years of having medication-assisted treatment within the prison. So this didn't happen overnight. This takes the culture change, and Kodak, the president sitting next to me to the left, should really speak to this, but she's been inside the prison having an actual opiate treatment program in the prison for many, many years. I think it's, what, 16 years or so?
94.
So
1994.
It started in 1994?
Yes.
So that started with just supplying methadone for women who are pregnant that were inside the walls. And then the information started to seep in about men and women who went in that were withdrawn from this medication. Why would they get withdrawn from this medication when other people who are on other diseased medications for diseases were allowed to stay on their medications? So the conversation started. Dr. Clark was such a leader. We already had Kodak. It was a perfect storm.
We are the only, right now, we are the only, well, 2 more have come on board, but we were the first state to provide all 3 medications for opioid use disorder when individuals came into the prison with a disease. The other thing that makes Rhode Island's program different, not only do we provide choice in all 3 medications, we also provide
choice to who, Linda?
Choice by the individual coming into the prison, and the decision is made between that individual and the physician who's doing the assessment. So the choice of all 3 medications, a buprenorphine, a Vivitrol product, or...
And how would that patient know? I mean,
often the patient knows because of prior utilization of the medicines. Frequently when individuals come into the prison, they've already experienced medicine for opioid use disorder. They know what works for them. And it's a very individual choice, because some medicines, just like if someone is utilizing a blood pressure medication, what might be a side effect that I couldn't tolerate, Dr. McDonald might be fine with, and vice versa. And it's the same way with the medications for opioid use disorder.
Do you find, even with the success that this program is having and the sustained success it's having, there are still people out there and go, why do you waste your time with that for? There are those people, they're lost causes.
There still is those misperceptions. There's folks that hold them, but there are fewer. There absolutely are fewer. You may have heard Dr. Clark or Linda state that in the population that had been recently incarcerated, in 2015, 24% of our overdose deaths happened in that population. And in a year and a half, we saw a 61% decrease in overdose death in this population since the inception of this program in fall of 2015, the enhanced program. You can't, it speaks for itself. It saves lives. 61% of those deaths, there was a 61% decrease. There's really not much more you can say about it. It's not—
Can't argue against those numbers.
Yeah, again, it's not, are you going to do it? It's how are you going to do it and when?
Christina Myers has a question from a viewer. Christina.
Thanks, John. This question was actually sent to us anonymously, and this person wants to know about the Rhode Island Department of Health looking into whether medical marijuana should be used to help treat substance use disorder. And do you think that's a good idea?
Brandon, would you like to talk about that?
Sure, and then I might let
or Dr. McDonald, maybe it's in your lane.
Yeah.
You know, it's a great question. You know, medical marijuana is approved for chronic pain, and that's really the most common reason why medical marijuana is authorized in Rhode Island. The literature that supports using medical marijuana for opioid use disorder is really very thin. And, you know, right now I'd say if someone was asking the question, there is proven treatment for opioid use disorder. Buprenorphine products work, naltrexone, the Vivitrol product works. We also know the methadone, and we have 3 proven ways of treating people. I would steer people more towards the evidence-based treatment right now, because right now there isn't a lot of evidence that medical marijuana is helpful just for opioid use disorder. Having said that, if someone's coming from a world of chronic pain and they're looking for an alternative, several evidence-based studies have shown that some people get help with medical marijuana, and that's available to them in Rhode Island if they'd like to choose that.
And I do want to bring the conversation back to fentanyl one more time. And I want to ask Captain Kenyon about this. In your experience, when people are using drugs, do they know they're buying drugs with fentanyl, or they just don't care, or it's a little bit of each?
Well, I think fentanyl is so prevalent now, I think they're getting it whether they want it or not. There are fentanyl test strips out there now, so people can test the product.
And are those available, and how do they get them, Zach?
I think they're just starting to become available. They're getting distributed now throughout the state through different organizations.
Do you guys have those?
But they will tell people if there is fentanyl. I don't know if it will stop the person from using that drug, but at least the person will have some knowledge. Providence, we're still very busy. We responded to 88 overdose runs in the month of January.
88.
And we gave Narcan 66 times in those runs, and that was just for the month of January. So we know people still need help. That's why we're available with Save Station to offer that help.
Well, the prescriptions are going down, but the overdose deaths are still high. Why? Because of fentanyl?
Yes, because of fentanyl, and I think those shouldn't be considered to be related. You know, I think we have to think about prescription drugs is how you enter into opioid use disorder. When you get to the illicit market, like Captain Kenyon said, people are buying fentanyl whether they like it or not, and the potency isn't predictable. You know, when people buy counterfeit oxycodone, it's not made by a pharmaceutical company. They don't know how much fentanyl is in there, so they don't know what they're buying. And reality is, we have to reduce demand, and if we can reduce demand on a population level from all kinds of opiates, I think then we're going to see that's one part of the solution. There's other parts of the solution as well. You know, the communities across the state have been very engaged. You know, 25 cities and towns got a plan approved by the governor's task force, and the other 14 towns are getting their plan approved this year. You know, all 39 cities and towns in this state are going to have a plan to address the opioid epidemic by the end of this year. That's something that's worthwhile to get to these social determinants of health, these larger issues. It's just not as simple as prescription drugs versus fentanyl.
I want to end it. We have just a very short amount of time left. Linda Mahoney, I promised I'd ask you this, and I want to bring it in. The state of Rhode Island getting millions in federal money. How will that money be used, and what's most effective use of it?
Well, our strategic plan is around addressing prevention, treatment, rescue, and recovery, and putting money in each area and understanding that people need to have access to care first. So a large part of the money went to our BH Link, which is 414 Link. You can call this number, or you can go to 975 Waterman Avenue, East Providence. It's like a triage center. It's 24 hours a day. It's 7 days a week. It's bilingual. You can call, ask for help. We know that people, when they get to that moment, they need help. We have to help increase the access, the capacity for systems, increase treatment, making sure we have peer recovery specialists that might meet them at the early stages, bring them to the warm handoff to the next stage. We want to be mobile. We want to go to where people are, not wait till they knock on our door, but we want many avenues for access. So you either call, you walk in, we ask if you want help, we distribute naloxone, we distribute fentanyl strips. The money came from stakeholders. We asked them, where's the gaps in the system? Where do we need to fix? How do we get better? We're not the brain trust. We've been around a long time, but we have to listen to the people, just like the HIV epidemic. Go to the communities and say, how can we make your community safer? How can we get you into treatment quicker? And then also, when people do get into recovery, they have to have sustained recovery. We have recovery centers, 5 areas in the state. We have centers of excellence that know how to deal with pain, 14 different locations in the state. Rhode Island is small. We can do wonders. And we're putting that money in really good use.
Well said, Linda. I'd like to thank all of you for joining us tonight. We really appreciate your time. Thank you so much. We'd also like to thank Brown University for hosting us this evening, and to all of our supporters who made this special presentation possible. And if you'd like to see any part of our opioid series or learn more about the resources that are out there, just go to our website. It's abc6.com. We've run out of time. What a fantastic panel discussion we had. What a fantastic event we had. We thank you so much for joining us. Good night, everyone. Take care.